It's election day. Have you voted? Well, we're going to talk briefly about that, but more about the other stuff that's happened in general practice over the past few days. And there has been some crazy stuff that happened, particularly over the weekend that's just gone, that everybody in general practice is talking about. So we're going to talk about the past, the present, the future as we tech enhance your primary care and learning. Hello, EGP learners, and welcome to this live episode with myself and Andy are talking about all the chaos and craziness that happened in the past few days in general practice. And we haven't even started talking about the big thing that's happening right now, today, the election, aren't we, Andy?
Yeah, the 4th of July. So I've been out and voted. Have you voted, Gandhi?
I have voted as well. And I've even put in the poll to see if other people have voted already as well. So if you have or haven't, then make sure you check that and stuff. And we're getting invaders coming in live on camera as we see how things go. I know.
So if you have something you need to deal with, Gandhi, you go deal with it.
No, I think we're okay. But yeah. But I hope everyone's doing all right there. Have you voted? That's the thing we'd love to know. So stick that in the chat if you have or if you haven't. We don't mind who you voted for. Please don't, tell us if you want.
Just make sure you vote.
Just make sure you vote more than anything else and stuff and things. So, but we've got loads coming up. What have we got coming, Andy?
So we've got a few stories coming up. So we're keeping it fairly light for you, actually, and going for the most impactful stories because the TV should get good later on as the election coverage starts to roll up. So we want to go off and watch that as well. But we're going to update you on BMA industrial action. That's probably going to be one of the big things in the inbox of the next health secretary. And there's been some changes to the proposed industrial action. So we'll update on that and make sure people know how to vote in what is also an important ballot, the BMA GP industrial action ballot. We'll be talking about plans around using SAS doctors and non-GP doctors in general practice that Katie Bramall-Stainer has been making some comments about and could prove to be as controversial or more so than the PA debate. We will be talking about the GP Connect story that happened over the weekend. So I think a lot of people's weekend was interrupted by pleas or directions or advice to change settings on their clinical systems. We'll be talking about that. And then we'll be making a recommendation for a podcast that might let you see into a possible future, in which Wes Streeting could be the next health secretary. Possible, probable, who knows? But there was a great podcast that just sort of like to direct you to. So, Gandhi, do you want to kick us off? I mean, shall we talk about the election and just how?
Yes. So first thing we're going to say is please vote. If you're watching us live, you've still got 2 hours if you haven't done so. Some of our EGP learners already have. So we've got a comment from Lucas Matt who says, yep, hello there, I voted. Interestingly, we've got other people with different priorities. Toby Wallace talking about, what about the tennis? So there is the men's British versus British match going on. Last I saw, I think Norris was winning 2 sets up or something like that. So yes, Toby, we are even watching the tennis as we live stream. That's how crazy we are here at EGP Learning and things. And Andy, we're talking about tennis on a tech podcast. There you go.
So yeah, I mean, how's election day been at Wellspring practice today, Gandhi?
Interesting, because actually my practice is a polling station as well. So the library that my practice is based in acts also as a polling station. Seen a fair few people coming and going. It was sort of a couple of councillors as well locally asking about who am I voting for and all that kind of stuff. I can't actually vote for where I work. I have to come back home, which I did, and I even took my kids with me to show them the voting process and emphasize why it's so important to vote and stuff.
Yeah, that's great. Yeah, we're also a polling station in our building. We also are connected with a local library downstairs. So there were more people coming and going and casting their votes during the course of the day. So that was really, really nice to see. We had some interesting conversations in the staff room today. There's a variety of views being expressed from medical students voting green, to some of our reception staff. Don't know how they're voting, but potentially attracted by some of the reform policies, some of the conservative policies, and some people, being attracted towards Labour. So really all political colours on display at Parkside Medical Practice today. So yeah, exciting times. Really nice to actually have some really quite healthy conversations actually about health policy, economic policy, how people saw things. I think the level of debate in the kitchen was elevated today due to the election. That was nice to see. Yeah, be interested to know what how election day has been for people out there
Yeah.
watching as well, and if they've learned anything interesting about their colleagues talking about about voting intentions, and
Mm.
so forth. Yeah.
And I guess if people did want to check out the manifestos, I mean, you still got a couple of hours if you wanted to, then definitely check out this episode that we covered a couple of weeks ago, which was myself, because unfortunately Andy was not able to join us, talking about the various different health policies and what the manifestos exist from the different parties and how that may have an impact for the future of our country and stuff. So we've talked about enough about the election, haven't we, Andy? You know, we don't need.
I think so. It's nearly in the rearview mirror. Quite frankly, you could have had the election probably 4 weeks ago, and I'd have been very, very happy. So I'm quite happy to see the end of it. Let's get on with what's next.
Well, what's next, unfortunately, is another type of poll of sorts and stuff. And this is around the stuff that's happening in general practice, around the change potentially in terms of strike options. So just understand it's a bit more deeper. So the BMA themselves are currently putting a poll out or a vote or election on. It's not quite an election,
Ballot.
is it? Ballot. That's the word I was looking for.
They are
Ballot.
balloting members on industrial action.
Yes.
Polls have opened. Polls close on the 29th of July, so you got a lot more time to vote on this ballot. Not everybody listening may be able to vote. It's just GP principals, so GP partners, essentially, who are eligible to vote because they are the contract holders for the GP contract. And the
Although
ballot,
an interesting thing to point out, even if you are not a GP partner, you could absolutely discuss it with your partners because, it may involve them more in the decisions about how they want to vote and stuff. I know my own practice team very much, we've discussed it a few times as to, the pros, the cons of what does exactly industrial action mean. And in particular, like you said, one of the key things is this change that's come through in terms of the potential strike options that exist for general practice. Because this came out a few weeks ago, it's a massive headline in terms of the various options that existed. And actually, the BMA have now made a bit more of a clarity in terms of some of those and what they may look like, haven't they, Andy?
Yeah, so there's now 9 options to pick from. Just backtracking slightly, Gandhi, I've just realised that we haven't discussed with the rest of our staff, and we've still got time to do that before the 29th of July. And I'm going to put that on the agenda for our practice meeting next week, because I think it's important to have that conversation. Because if we're doing things that are industrial action, they'll be doing it along with us. They're actually having to do these things, which might make people feel a little bit awkward. And I guess that leads us into if practices vote in favour of taking industrial action, what might that industrial action look like? So the story that we were talking about in terms of things changing is that the GPC removed 2 of the options for industrial action from their guidance. So I think they were going to suggest that GP practices might switch to face-to-face only appointments, and due to feedback,
I think that's a different article to the one you're showing, Andy.
I do apologise. Here we
there
go.
We go.
So but I think in response to feedback from practices about kind of how feasible that might be, that's been dropped from the industrial action menu. What was the other thing that was dropped, Gandhi? I'm just trying to remember. Do you remember?
No, unfortunately, I don't. I thought that was the main one.
That's the headline one.
Yeah.
Let's have a look at what the menu is, and I think that's probably a good opportunity just to link through to actually BMA's campaign center and the page around voting. So if you're not quite sure how to vote, then go to the BMA website, go to our campaigns, go to the GP campaigns, and go to all campaigns. You'll find your way through to the GP contract campaign, and there you can log in, join. You can still join and vote. You can log in, update your details, and then click through to vote in the ballot. So what people are voting is to whether they support industrial action or not. And then afterwards, if industrial action is supported, then they're suggesting that from the 1st of August, industrial action starts, and that GP practices put in place a combination of any of 9 suggestions. So I guess just to quickly run through them, these are limit daily patient contracts to safe working levels as defined by European bodies. So that's 25 patient contacts per day, then divert the rest of the activity elsewhere once safe capacity has been exceeded. So that's 25 contacts per GP per day. Stop engaging with electronic referral, advice and guidance pathways, unless you feel that it's clinically appropriate and helpful. So where those things are not felt to be helpful, you stop engaging with them. And I think either here or elsewhere they suggest reverting to sending typical classic referral letters instead to the relevant departments. Stop supporting the system at the expense of your business and staff. So things that you are doing voluntarily or that you're not contracted to do, stop doing those and stop plugging commissioning gaps. Stop rationing referrals. So I think often we are asked, to ration referrals, not to refer unless certain criteria are met, but to revert to referring where you think that is clinically appropriate for your patient. To stop rationing investigations and referrals. Switch off the GP Connect functionality to permit entry of coding into GP clinical records by third-party providers. So I think that's something
We're
that the
VMA
got ahead of over the weekend. So we'll come to that. That's one of our other stories. Withdraw data sharing permissions and agreements that aren't required for direct patient care. Stop signing up to new data sharing agreements that are not required for patient care. Switch off medicines optimization software that the ICB have embedded in their clinical systems, where that is in place for financial purposes of rationing and not for the clinical benefit of patients. And actually, I think it's a little bit of a mixed bag with a lot of that software, because actually it does do quite a lot to enhance clinical safety as well as direct us to more cost-effective prescribing. So I can see it could be difficult to switch off one without switching off the other. So that could be challenging without the cooperation of the ICB, which may or may not be forthcoming. And there is some concern about signing up to the better digital telephony, crowd telephony agenda, particularly around data sharing. I think there's a fear that that data might be used to performance manage practices, and that perhaps that data is business sensitive to practices and might be used for unintended purposes by NHS England. So those are the proposed industrial action. I don't know what people think about those, and whether there are some that people feel really comfortable putting in place on the 1st of August, some that make people a little bit more nervous and uncomfortable putting in place.
Potentially. I mean, so Dave McConnell comments about that makes perfect sense to drop that. I think he's talking about the face-to-face contact ones. And I know that was probably one of the more contentious ones, because particularly with many practices shifting towards total triage and seeing some significant benefits in workflow and stuff that can happen. I think there are practices where they found that the online route has actually given them a sense of control, and actually shifting to a purely face-to-face model actually would reverse a lot of the positive work that they've done that has actually improved not only the access for patients, but actually the quality of life of those clinicians and people working within the practice. So I can see why they've dropped it. I must admit it was the one I struggled the most to understand, because would I move to a complete face-to-face model? No, because actually the 25 contacts would mean, yes, I would be doing industrial action and probably challenging the government to understand how amazing general practice is. But would I be doing an amazing job for my patients still, and a safe job for my patients? I probably struggle to feel that was the case for the system that I have already within my practice. Maybe different elsewhere.
Yeah, and I think that's one that would cause a huge amount of disruption for practices that have adopted other models that rely on other entry points and other ways of consulting, whereas some of the others actually are really creating more of a headache outside of the surgery for other parts of the system. And I think that's probably the intention of this action, not to make GPs' lives harder or harder than they are through the type of action that's taken. So that's that really. And I guess that is an important ballot. Please consider voting. Please do vote if you're a GP. I was going to say please join up, but I'm not a salesperson for the BMA, so make a decision as to whether you want to be a member of the BMA or not to participate in that. But you can't participate if you're not a member.
And if you didn't want to be, there's nothing saying you can't sign up and then leave afterwards.
Cancel it a few weeks later. Yeah, maybe.
Exactly.
Yeah,
I think you get 3 months free as well anyway. So there you go.
Without labouring the point, it might be worth just reminding people why the GPs are considering taking industrial action. I think regular listeners will be familiar with the arguments, but there was a new contract imposed in April with a 2% increase in funding, effectively, so less than inflationary increase in funding for core general practice, on top of multiple years of roughly 2% increases in funding for the last 5 years, which has left GPs. I'm forgetting the maths now, but I think funding would be somewhere in excess of, is it 15% higher than it is now? It feels like it would be more than that if we'd had inflationary increases, but funding would be in a much higher place. And there's a suggestion from the BMA that they were asking for, I think, 8.7% in order to bring funding in line with where it was in 2017 in real terms. So before the last 5-year settlement started, if we had had inflation increases just to keep pace with that, I think we would be at 8.7% higher than we are now. So that's what they were asking for, much less than the junior doctors. And I think that was sort of a starting point for negotiations. There might be other things that they would ask for as well. They want to get the government round the table to have a discussion about the contract and don't want to accept the contract that was unilaterally imposed in April. So that's why the industrial action is taking place. We're not talking about striking. So there we go.
Yeah, and I guess, well, before we get to that, a couple of comments. So Neil Moody, I was looking forward to turning off 111 direct booking into slots. Is this the other one that's gone? It seems to be. I can't see that on the current list, so maybe that is the one that the other one.
Yes, that's the one. I remember. And thank you, Neil. That's really helpful. It just jogged my memory. So that's the one. And I think the reason was that the BMA were taking further legal advice about that. So it might be that that's just legally more challenging in some way for practices. Thank you very much. People are very on the ball out there.
Thank you. So just before we get onto our next story, just a little bit of a news item I love to give every time this happens. So we've got over 100 people watching us live. Thank you, everybody, for joining us. Again, hopefully you have voted. And if you have not done so, please go out and vote. You've got 1 hour and 37 minutes to do so, I believe it is, at this time of filming and stuff. But the next news story is probably the one that absolutely went bonkers this weekend. And that's something weird called GP Connect update of record. Right. Shall we get into this, Andy?
Yeah. So what happened over the weekend was from numerous different WhatsApp groups I had Katie Bramwell-Stainer popping up in a video asking us to make changes to data sharing settings on our practice clinical record system. And there was a huge response with lots of, with all sorts of GP surgeries saying, turn it off, turn it off, turn it off. People taking action. I messaged our practice manager and, made some changes to our settings as well. So it's really quite interesting how the profession was able to mobilize over a weekend through all of these social media connections, which apart from the story itself, I thought was really, really impressive. Gandhi, you did a video as well explaining the situation and how people can make changes that was really welcome. And I saw that in a lot of the groups as well being shared. So that was sort of my experience of it. But Gandhi, you know a lot more about the inside of this story. So tell me what was actually going on.
So I guess the key thing about this is that back in April, when the contract changes came through, part of that was adding in additional data sharing requirements. And one of those was something called the GP Connect update of record. So this is part of the GP Connect system, but it's a separate part. And what this effectively means is it allows for other entities to directly input information into the GP record. The reason why this was originally brought in was to support one of the other major initiatives that's happened in this past year, which was Pharmacy First. So the ability for pharmacists who have assessed patients out as part of the Pharmacy First scheme to then input that assessment and that information directly into the GP records. Now, depending on which system you're on, there are different levels that this can happen. So some of the systems is a all or nothing. Some of the systems allow that information to be sent, and you can then tailor it for that to be either a notification to say that actually, do I want to add that in or not, or directly in or not at all without another route being sent. So the reason why this became a key issue is, according to the GPC and the BMA, just before the weekend, they were alerted that NHS England were instructing the system providers, so the two big ones being EMIS and System 1, to remove practices' ability to switch this function off. And obviously, once the practice abilities of that has been taken away, for them to then change those settings is almost nigh impossible. And the concern I think the GPC had, as outlined by Katie Bramwell-Stainer and others within the area, is that effectively, whilst this is predominantly created as a route for pharmacy first, there is nothing stopping any other qualified provider, as determined by NHS England, for using the exact same mechanism to send that information into the GP record. Now, there's probably a lot of people thinking, well, that's a great idea, isn't it? Why would you not want to do that? Well, the issue with that is that there's a significant workload and liability responsibility that comes from that level of information sharing. So there's absolutely could be situations where a third-party provider sends information that goes directly into the GP record without the practice being aware of it, and they're not aware of the consequences of that information, like, for example, a new diagnosis, like, for example, coded information around that patient that may or may not be correct. For example, a classic one is a patient checked with a high blood pressure reading being diagnosed with hypertension off a single reading, which may or may not be correct. And that's then given that person a label of a chronic disease, which the practice, if they'd set it to, no restrictions, would not be aware of that and wouldn't be able to understand that until they went back into the patient's record at some point, and it could be incorrect. And then there's also the question of the right of removal. How does that work if it is incorrect? There is absolutely further examples. So many were made about people having ADHD diagnoses given inappropriately, asked for medication inappropriately, various other routes that happened. So this all came to a head late last week. As a result of that, the GPC recommended that practice switch off the ability for that information to be sent before the ability was taken away from them. Subsequently, over the weekend, no information came out from NHS England. However, on Monday, two pieces of information came out. So both the major system providers, EMIS and System 1, stated they would never do such a thing, and that they would inform, obviously, practices if such a requirement was made. In addition to that, NHS England said that they did not make such a request. Now, there are some thoughts out there that would be obviously what they would say. Whether it's true or not, I think is up to individuals to make an inference from there. I think the bigger thing for me, and this is the thing that, so I recently talked at the Leicester and Rutland LMC event on the following day, the Tuesday. And the one thing that stuck out for me is that what we did see over the weekend was the ability for general practice to stand up and respond to something and do so in such a way that has, in my view, not been seen ever. And it was marveling in some ways. Don't know what you thought, Andy.
Yeah, I thought the ability to mobilize on the issue was really, really impressive. And it reached me on a Sunday, which I'm not. I try and switch off and away from social media, particularly at the weekends these days. But it got cut through with me. Most GPs, I think, were aware of it. So just really, really impressive, actually. It's interesting that they didn't take those permissions away and said that they were never planning to do so. And I guess we may never know the truth of whether it was real. But if that was an intention or even being considered, it's not being considered anymore. And the response from general practice may be the reason why. So yeah, quite impressed, really. So
I think it's important to recognize that there may be consequences from switching it off. So, whilst, many people feel absolutely this is something we have to do, it does mean that information from Pharmacy First does have to come to you through another route, and that may create some additional workload because it's a more complicated route. It could be scanned PDFs, it could be in emails and stuff. And obviously, this may impact future areas where actually that level of data sharing could be a really powerful and useful thing. So, that's not to say that it is the right decision to make longer term. I think the benefit of people having had it switched off is they've got more control now over that data. And important to remember that the GP partners are actually the data controllers of the record. They are the ones who hold the liability of the information that goes into that record system, not NHS England. And this was some of the complexity that came around having patients having open access to their records as an automatic switch on, which was obviously a key contention that in order to make that happen, basically they had to write it into the contract to make that happen, which was still a significant area of contention for many practices because it's a liability issue in terms of who are you more scared of, the ICO or your NHS England.
Gandhi, was free text included in that, or is it just coded information that was going to be pushed through? I didn't quite understand that at the time.
I believe it's mainly coded, but I
Yeah.
can't remember off the top of my head if it excluded free text as well.
Yeah, I mean, I hope it wasn't free text. I didn't hear people talking about third-party data and visibility of that and so forth. So I'm assuming it didn't, but those would be, big concerns as well if there was free text. But maybe it wasn't because people were not really having that level of discussion. So, but that was big, and I think that was nice to see everybody mobilize quickly. So that was really, really good.
And I just want to say thank you to all the GP learners who commented on the video that I put out showing how to make those changes directly in System 1. And also shout out to Dustin Stain from Primary Care IT, who also created the guide for how to do that on EMIS practices, because unfortunately I don't have access to EMIS. But, real stand-up abilities from primary care. And for me, that was the big thing that came out last weekend.
So, next story. SAS doctors' plan will bring demise of GP profession, says GPC chair. So KBS Katie Bramall-Stainer is really good actually at generating pulse headlines. At least I don't know quite how much cut through she'll be getting in a general election across the general media, but I think she does a good job of highlighting issues. So Gandhi, when changes to the GP contract came through early in the year, you identified some changes around the prescribers list and the ability of doctors that aren't qualified GPs to practice, or aren't qualified GPs and are not GPs in training to practice, or F2s working under appropriate supervision to practice in general practice. And it looks like these are now being identified as a potential source of problems, even potentially causing the demise of general practice. So what was it that you'd sort of spotted in the documentation a few months ago?
Yeah, so there were performers list changes back in April as part of the GP contract change that allows basically non-GPs to basically work in general practice. So some people out there who aren't aware of how things work, effectively, in order to be a practicing GP, you can only do so if you're either a qualified GP on the performers list, so it's a list of people who are safe to practice in general practice independently, and that's the key thing that comes through, or you work under the supervision of a GP, and that's where, for example, like GP trainees, nursing teams, other roles and stuff function and things, but they can't practice independently without that support structure. So for example, a practice around them. The contract changes that came through basically enable non-GP doctors, so for example what's commonly classified as SAS, so services seen doctors, to work in general practice. So this could be a hospital doctor working directly in primary care. Now, many people probably thinking, well, that's a sensible idea, isn't it? It helps fix the problem. The challenge with that is it comes down again to responsibility and liability, because actually, if you have an orthopedic doctor working primary care who then is in a situation where they're having to work outside of their competencies because what they're trained in is orthopedics, not in general practice, how does that work? And actually, does that become sensible? Is that safe? Is that appropriate care? And as Katie Bramall-Stainer is saying, actually, this could be potentially even bigger than the whole concept of PAs and AHPs working in general practice, unsupervised and unregistered and stuff, because actually the risk to the existing workforce is significant. But more importantly, I think there's an element of, do patients know that this is happening? And they change in terminology to using primary care doctors, I think it says, instead of GPs for the term of doctor in primary care. It is a significant one, to be honest. So yeah, I think personally that was the biggest consequence out of the contract, not the 2% like many people cited and stuff, but it seems like that's the case now.
Yeah, I mean, just to give my 2 cents worth, I guess. So I think a lot of people who don't understand the training structure don't necessarily understand that in order to be a GP, you need to have completed a basic level of hospital doctor training, and then you do 3 years of specialist training in general practice. And the difference between what doctors are doing in general practice and in most hospital specialities is that you're seeing patients just walking in off the street. You're the front door. You're seeing a completely unfiltered stream of patients who may not be very unwell at all, or may be critically unwell. And
Mm-hmm.
skill is having that breadth of knowledge to deal with just about anything that walks through the door. That recognition of who is ill and who isn't, and to do that quite quickly, how to manage them appropriately, both acute illness and long-term conditions, and to do all that in an environment that is very different to a hospital, where you don't have immediate access to really many tests at all. It can be a few days to get blood results back. There are no x-ray machines or scanning machines on site, so it's a really, really different environment, and you're dealing with really, really different types of risks. So actually you do need some, you might think, oh, GPs, they're generalists, they're not specialists, the level of training isn't necessarily going to be that high. But actually, with specialist generalists, actually to work in that environment requires a high level of training and familiarity with that environment. So a lot of GPs will have concerns about people moving into general practice and being unprepared to practice safely in that environment without supervision. And actually, a lot of senior hospital doctors often say, actually, it sounds like it would be really, really hard to be a GP, outside of the hospital and seeing unfiltered patients in areas that I'm not experienced in. So I just want to really drive that home, really, the risks, both potentially to patients, to the profession in terms of undermining that specialist role that GPs have, and also the safety and comfort of those doctors who might be forced to work in general practice, having perhaps wanted to go into other areas of medicine, but feeling that they have to take a job working in general practice. They might operate at levels of risk and stress that is very, very uncomfortable for them. So that's where I have a lot of concern, really. You can see how, superficially this sounds good, doesn't it? We don't have enough GPs, maybe GPs are expensive. Can we actually use these other people who are trained as doctors to do the job? Superficially that sounds quite attractive, but without the right supervision in place, I think it could not work very well. And also, I think the parallels drawn with the physician's associate debate are interesting, because there's been quite a lot of friction, if people hadn't noticed, between physicians associates and GPs to some extent or lesser extent. And it would be really ugly to see that kind of within the profession itself, I think, between SAS doctors and GPs. So it would be great if we can avoid this, but it may be coming.
We shall see. I guess the other thing that we shall see as well is basically the potential of more information from who may be our future health secretary. We'll find out tomorrow, won't we, Andy, and stuff and things. But so this is an article that we saw that came up in GP Online. It was talking about a podcast interview with Wes Streeting. Andy, do you want to tell us a bit more about it?
Yeah, so let's just imagine for a second that Labour might win the election. So Wes Streeting might be the new health secretary. So this was just an interesting podcast that I just want to draw people's attention to, because I think people will be thinking, what's Wes Streeting got in store for general practice? If he is the health secretary, what is Labour cooking up? It's just a really quick interview with Wes Streeting. It's about 15 minutes long. It's available anywhere that podcasts are delivered to you. It was really, really interesting, actually. I think the things that I took away from this were that Wes Streeting sounded like he'd spoken to GPs about the problems of general practice. A lot of the language he was using and issues he was raising are things that I think he will have heard from GPs. I think big takeaways were we might remember comments that he'd made about the partnership model at the beginning of the year. And I think Labour have completely sort of backtracked from hostility to the partnership model and now accept that that is probably part of any future for general practice, and a much more kind of delivery mechanism neutral around general practice. And I actually think that there's a lot of benefits from partnership. So they've changed the language on that. And the other thing was that he was talking about seriously exploring making ARS funding available to fund GPs and practice nurses, which I thought would be a really big change. And that's something that there's been a petition to ask for that we've covered before, that a lot of people are asking for in an environment where all the new money for general practice has come through the primary care network. DES over the last few years with only small increases to core general practice that can actually be used to pay for GPs and practice nurses, making some of that money available for GPs is something that a lot of people have asked for, and it looks like they're warm on that idea. So that could be a really big deal. So just thought that was an interesting podcast to listen to.
Definitely. And people want the links to that, then do have a look down below. I guess this is the point that I'm going to make an open invite to whomever is our new healthcare secretary, and particularly if it's Wes Streeting. If
you're listening, Wes, live on election night.
Exactly.
You're glued to EGP Learning. Come and join
But
us.
if you are, and if you want to come and speak to general practice, this is an open invite for you to come and join us on the live stream. And actually have the opportunity to speak to grassroots general practice and get that message across. And, no health secretary has taken us up on this offer yet. Will we see the first one ever happen? We shall see. Labour particularly claim that they're going to be different. Maybe we will see. None of the Tory ones, the 7 or so we got through, isn't it, Andy, in the past few years?
To be honest, Wes he's been doing the rounds in some of the GP podcasts, actually, and I'm not sure I've seen other health secretaries or potential health secretaries do that. So hats off to him.
So open invite. Want to come and join us? Want to come and speak to primary care? This is the best place to do it.
Good. So that might be a good place to end where we started with. Please vote. You've got an hour and a half left, probably less, to go and register your vote, and then sit back in front of the telly. And
it seems like many of our EGP learners have done that. So looking at the polls that I put out about numbers voting and stuff, so 77% have voted. That does mean that there's a fair few that haven't. So please go out and do so. And as always, we will be here to help inform you about what's happening. Next week, we've got an interesting episode that's talking about basically what the new government could be looking at when it comes to health challenges and particularly health inequalities. And that's a document supported by the Health Foundation. If you want to check that out, have a look right here. Alternately, we obviously have more information for you coming up right here. And as always, we'll be here to tech enhance your primary care and learning. And we will catch